Hi, everyone. It's great to have you here today. My name is Erin, and I am the program coordinator for our project ECHO here in East Africa. We are in our mentoring sessions at the moment. We recently completed a certificate course, which is the 11-week program focusing on an introduction to palliative care for clinicians, multidisciplinary humanitarian healthcare workers. An introduction to palliative care. So we are in our interim phase right now where we're doing mentoring sessions every 2 weeks. And it's really great to see some new people on the call with us today. We have, the way we structure our program is we have a 20-minute teaching time or a didactic lecture where we learn from an expert in the field of palliative care. And then we move on to a case discussion. So we will have plenty of time for questions and answers. If you are able to rename yourself, in the very top corner of your Zoom video picture, you'll see 3 white dots and a blue square. If you click on that, you're welcome to rename yourself. You can put your name, maybe where you're working, so we can engage with you. Yeah, we're very excited to have you here. This is a joint program with Palliative, which is a global network for palliative care workers supporting clinicians in humanitarian settings, as well as KEHPCA, which is Kenya Hospices and Palliative Care Association, which is our national association here in Kenya, and Two World Cancer Collaboration, which supports palliative care initiatives all around the world. I'm grateful to introduce Dr. Esther Muinga, who is staff with KEHPCA, as well as the Ministry of Health here in Kenya. And she specializes in pain and palliative care. So welcome, Dr. Esther. She is going to share her screen and she's going to be teaching us on pain management. And then we will move into a time of discussion. So welcome everyone to our call today.
All right. Good afternoon, everyone. I'm happy to be joining you this afternoon, and it's nice to see all of you ready to learn from each other. So let me just share my screen, and then we'll be able to start it off. So today's session is looking at pain management and use of opioids in humanitarian settings, related view of your services, and I hope they're useful. Am I audible?
It was breaking a little bit. I'll try again.
Okay. Apologies. We have challenges with the power and internet today, so I think it's affecting the connection. Is it okay now?
Yeah, now it seems to be all right.
Is it still breaking, Erin?
Yeah, maybe it is. There just seems to be silence from your side.
Any better now?
A little bit, yeah.
Sorry for.
We could, Esther, because I'm doing the case presentation, we could do the case first and then see if it clears up. You want to try that?
We could do what? Sorry.
I could do the case first, maybe. Yeah, I think Leonard is also saying it's breaking. We could do the case and then have a discussion on the case and follow it up with the teaching. Would that work? Maybe the connection will be a bit better in half an hour. I think maybe we'll do that. So
Okay.
just while Dr. Esther is finding a bit of a better connection, we'll move on to the case. So the way that our Project ECHO works is that we try to bring in examples from the field that we can learn from as a group. So what we will do now is we will talk about a specific patient in a case. So if you have particular questions, you're welcome to put them in the chat. And we'll make sure that we spend time during this case presentation to answer those questions. So let me share my screen. Okay, if someone can just maybe do the thumbs up if you can see that properly. Are you guys able to see my screen well? Okay, so I want to introduce you to a patient for our session for today. He is a 35-year-old man in an inpatient unit. And as you can see from the photo on the right-hand side, he has a fungating head and neck cancer. For this particular situation, which we find in many of our humanitarian settings, his oncology treatment is not available. He wasn't able to access treatment for his cancer. And he presented in our clinic with very advanced stage disease. The main issue for our patient here, this man, is that his severe pain was actually preventing him from sleeping at all. As you can see, he has a severe disfiguration of his face where his cancer was, and he has a huge wound on his head. So as we think about pain assessment, especially in our patients who are not able to access any type of treatment to reduce the size of their cancer or to slow the spread of their cancer, we often find our patients are in pain. So for this patient, he had continuous pain all over his face, the large areas of his face where the wound was. And he stated his pain was a 9 out of 10 in severity. So as we teach about pain and pain assessment, we often try to teach our patients to try and rate their pain on a scale out of 1 to 10. 1 being no pain at all, and 10 being the most severe pain they've ever experienced. So this patient, you can see, had extremely severe pain. He was rating his pain as a 9 out of 10 in severity. He stated then that his pain was worse at night and it often prevented him from sleeping at all. Especially the pain also grew at the time of his dressing when we had to change his dressings in the clinic. He did receive some relief from morphine immediate release, 10 milligrams as needed, PRN. And this was given before the dressing changed, and his pain score was reduced to a 7 out of 10 during that time. So we know when we if you've been in our certificate program, you know that a 7 out of 10 pain is still severe pain. And as we will learn shortly from Dr. Esther in the teaching time of our session, anybody who's experiencing over a 6 or 7 out of 10 is in extreme and severe pain. And we want to make sure that we do our best to manage pain so that it becomes much lower than that on a scale out of 1 to 10. Other symptoms that our patient had at this time was a reduced appetite. He experienced low mood, and of course, the poor sleep that we talked about earlier in the case. He had malodor from the wound, so it didn't smell very good, and it was causing him a lot of stigma. And he experienced bleeding during his dressing changes. As you could see from the photo, there was quite a lot of areas on the wound that seemed quite raw, and that's where the bleeding was coming from. He also experienced itchiness at his wound site. As we think about his social and his spiritual needs, he was married with 5 children. He was the father and a caregiver, although he had long stays during his inpatient admission. He was staying quite far from his village, and he had a Christian faith, which was quite important to him at that time. So I have a question here. If you can take a minute to put your comment in the chat, I would love to see, as you think about this case, as I've explained it, how would you manage this patient's pain? So we just talked about the fact that his pain was a 9 out of 10. And with the use of an as-needed morphine dose, right before his dressing change, we were able to reduce the pain to a 7 out of 10. So what else could we do to manage this patient's pain? And in particular, which medications would you use based on your previous knowledge, if you've partaken in any palliative care training before, or if you've done our certificate course, and what dose would you use? So currently, I can go back. Currently, we were saying that he was taking morphine immediate release 10 milligrams as needed. So take a minute during this case discussion to just jot down in the chat, what would you do to manage his pain, and which medication would you prescribe or would you suggest? If you're on a team and you don't normally prescribe opioids like morphine, then you could recommend something from your previous knowledge. So just take a minute and put in the chat what your initial thoughts are. This is a safe learning environment. So even if it's just an inclination, you're not totally sure, any suggestions would be great. Okay, so Leonard is sharing that he believes the patient has total pain. So we need to make sure that we work as a whole team to support him, and definitely think of breakthrough pain or procedural pain. That's really good. And we need to make sure that we escalate his morphine to continuous release, possibly 30 milligrams Q4 hourly. I think that's a really good suggestion, Leonard. Anyone else? As we've identified, this patient seems to be in a lot of pain, as he rated his pain a 9 out of 10. Okay, Stephen is recommending oral liquid morphine, but he doesn't know the formulations or the dosage. In Uganda, they give 5 milliliters of 5 milligrams of morphine every 4 hours. So that would be good. So in this situation, he has had a as needed dose of morphine at 10 milligrams. So if you have 5 mils of 5 milligrams of morphine every 4 hours, he would definitely be getting more, which would be good. And then Stephen suggesting maybe using medications towards neuropathic pain. Neuropathic pain is really important that we assess that as well. So at this point, I don't think we have enough information on the case to identify that he has neuropathic pain. Right now, he described his pain as continuous over his wound, and his pain was worse at night. So when we talk about specifically about neuropathic pain, we often talk about burning sensations or sharp needle-like pain. We've got some really good suggestions coming in. Thank you. So Diana is saying 10 milligrams of oral morphine for hourly. So that would increase his total daily dose of morphine quite a lot, which is great, Diana. I think that would be a really good step. Stephen is suggesting measures on social or psychological aspects. Perfect. Muriel is also suggesting morphine 10 milligrams every 4 hours and then 20 milligrams at bedtime. So this is a really good technique. Thank you, Muriel, for this idea. So we sometimes talk about a double dose of morphine at night, because we know oftentimes if patients wake up at night, it can be quite disturbing to them. So I think that's a really good idea. The only thing that I'm a bit nervous about of 10 milligrams every 4 hours and 20 milligrams at night is currently his total daily dose of morphine has only been 10 milligrams because he's been only taking it on dressing changes. So I think it's a really good idea, Muriel, to make sure he has better better management of his pain. But I'm wondering what your thoughts are and how he would have any side effects of the morphine if we increase his dose quite a lot. So if you want to take a pencil and a piece of paper, we'll do this together. So if this patient had 10 milligrams of morphine 4 hourly, what is his total daily dose of morphine, including the 20 milligrams at night? Muriel, would you be interested in unmuting and helping us walk through this calculation? I think this is really important as we find better ways to support patients taking morphine. Muriel, if you're there, would you like to unmute? I think you have some really good ideas in your suggestion. Diana's continuing with breakthrough doses. And Emmy also saying morphine 10 milligrams QID, as well as other pain management. She's suggesting the amitriptyline more for helping with sleep. So I'm assuming you're suggesting amitriptyline at night. That would be good. Also, Muriel has suggested amitriptyline at night. Looks like Muriel has been thinking about the big picture. So she's also suggesting the bisoprolol for the constipation that many of our patients experience once they start on morphine. So that's great. Those are really, really good solutions. Morphine 30 milligrams. So Diana is saying the total daily dose. So sometimes we write that as total daily dose, TDD, of morphine. You're saying is 70 milligrams. So we have a patient who's getting Q4 hourly. So if he starts at 7 a.m., after 4 hours is 7, 11 a.m. And then again, 3 p.m. And then again at 7 p.m. The 11 p.m. dose, I believe, with what Muriel is suggesting, would be the double dose. So then we have 30, 40, 60. I've got 60, but Diana, I could be off with my numbers. Okay, Muriel, you can't talk right now. That's fine. But thank you so much for your great suggestions. Ali is suggesting morphine 30 milligrams. And we have another person joining us from Iraq, which is great. Thank you to everyone who's joining from all the different areas. So I think we actually have some great suggestions. Bundi has suggested a opioid plus an adjuvant, and then an NSAID, which would be a non-steroidal anti-inflammatory, which could help with the symptoms. Okay, so let's get back to the case. We've done a lot of work here. Let's see what we suggest now. So if we look at this man who's 35 and has a serious wound with severe pain, one suggestion could be is morphine immediate release, or the liquid morphine that Stephen was suggesting, 10 milligrams every 4 hours. So I think most of you who have had some background in palliative care training, or you work with palliative care clients regularly, had suggested this. So it's great. We're definitely in line with that. And then suggesting an as needed or a PRN dose of morphine. So in that sense, we would suggest only to max this out hourly and 1 hour before a dressing change, which often the dressing changes are once a day. We are in line with the regular bisoprolol, which is a laxative to help to prevent any constipation, as well as possibly lactulose, 15 milliliters twice a day. So as we have given this patient this new recommendation, which is definitely in line with some of your suggestions on the chat, which is great, the patient has stated that his pain reduced to 6 out of 10, which is good, and his sleep has started to improve. One thing we noticed, though, is that he is using 3 to 4 PRN doses in 24 hours. So now things are getting a little bit complicated. We are getting better pain relief, but he's using quite a lot of as needed dosing in 24 hours because we're monitoring that, or we're writing it on his pain log. What would be our next step? So from some of our people on the call today, from your experience, as your patients adjust to a regular dosing of morphine every 4 hours, what's the next step? What do you do when they start to do more PRN dosing? When they start using their as needed or their breakthrough dosing, which is what we sometimes call it, more often? What is the next step? Okay, we've got some suggestions for IV morphine every 4 hours. So we do try as much as we can to avoid IV morphine because it ends up becoming an issue when we plan to discharge patients. A lot of our patients are not in hospital all the time. They do eventually go home. So we do try to switch as quick as we can to oral morphine, but IV morphine is an option. Why do we use morphine instead of other painkillers? So we know that morphine is an accessible drug that is affordable. We do know, unfortunately though, accessibility of morphine in humanitarian settings is difficult. So morphine is the gold standard for palliative care and pain management, but we know that it can be quite difficult sometimes to access it in some settings. We do suggest it because it is, we can find it as immediate release, and it is an affordable drug in Uganda. I'm not sure if it's near where Stephen is working, who's calling in today, but they have been able to manufacture morphine, oral morphine, and get it to many of their clients and patients in Uganda, which is great. And I think also here in Kenya, we through KEHPCA, we also are able to manufacture and create our morphine from morphine powder, liquid morphine. Lemek, I see your question, which is great. I will answer it when we go a bit further in our discussion. So some of the people on the call that responded on the chat, like Muriel or maybe even Bundi, do you have any suggestions on what you would do in your setting if you noticed the patient had reduced pain and their sleep was improved, but you did see that they had 2 to 3 as needed doses in 24 hours? What would be your next step? Okay, Stephen says we can increase the dose. Perfect, you're right. So, and monitor for the next few days and continue to add. So currently I see you say add on a step 1 analgesic. So currently using morphine on our analgesic ladder, according to what Dr. Esther will teach us, hopefully in the next stage of this call, is we've actually gone beyond step 1. So using morphine is an opioid. So we have gone beyond that. Welcome, Simon. Dr. Simon, thanks for being on the call today. We're glad to have you here. We have people calling in from all over today, which is great. Okay, so I do like the idea of adding in adjuvants. I think what we could do though, is we could add to his Q4 hourly dose. Let's see what the case says next. All right, so in our case with this patient, what we've actually done is we've increased his Q4 hourly dose to 20 milligrams. And we've continued to allow him, because of the amount of pain and the distress that we assessed in this patient, we were also able to manage his as needed dose to 20 milligrams immediate release. And again, we also wanted to increase his immediate release dose before his dressing change. And we realized that it wasn't until we made these increased doses for his regular dosing as well as his as needed dosing that we actually were able to control his pain. If you remember our patient, I want to go back to, I know a few people have joined later. Remember our patient. Do you remember his fungating wound? I want you to take a look at that picture. And I know it's very difficult, and I know all of you are doing excellent work where you are. But I think we all acknowledge that somebody who has a fungating wound that to the size of this patient would have advanced and severe pain. And prescribing this patient only an as-needed dose of 10 milligrams of oral morphine is not enough. As we could tell, his pain was a 9 out of 10 when we saw him initially. It only went down to 7 out of 10. That's not enough for pain to be controlled. So it wasn't until we increased and titrated his dose up to 20 milligrams every 4 hours and an as-needed dose or a breakthrough dose of 20 milligrams with the as-needed or the 20 milligrams immediate release before his dressing change that we actually noticed his pain was controlled. Because he was on quite a high dose of immediate release, we were at this point able to change his morphine to 60 milligrams of sustained release morphine every 12 hours. Taking medication every 4 hours at a high dose, such as 20 milligrams, is quite a lot, and it can be difficult. We could run into situations where patients could forget, or they go through a lot of the medication in a very short amount of time. So in our setting, we are able to access sustained release tablets. So therefore, we then could switch him over to now only having to take his medication twice a day or every 12 hours. We still continue to advise the patient to have access to his immediate release or his liquid morphine 20 milligrams, because we know that he may still experience breakthrough pain. So even though he's taking high doses of morphine, he could experience pain that comes through that dosage. And we do know that the most painful experience he has each day is when he has his dressing change. So we still will recommend that he takes his 20 milligrams immediate release before his dressing change. So other things you guys talked about in the chat that we would try to manage, and we will be sharing these notes with you through a Google Drive document. But other things we did want to manage and we did want to talk about today is the itch that he experienced. So we thought we could prescribe an antihistamine at night to help with this symptom and this pain. We don't want to ignore symptoms that our patients share with us. So we do want to suggest that. Also, with the improved pain and the antihistamine at night, we noticed that the patient was able to sleep. That was his prime priority, or his main concern when he came to see us, is that he couldn't sleep at all. His mood started to improve because we were controlling his pain. And also we began to suggest some mental health support for this patient. For the malodor or the bad odor that the patient experienced on his wound, we suggested to crush metronidazole tablets, and we applied this to the wound, and it greatly impacted the odor that was coming from the wound. And for the bleeding, we then also suggested to apply tranexamic acid to the gauze, and we applied it directly to where it was bleeding while we were doing the dressing change. And this also supported the patient. So as we think about this patient and think about what we did for this patient, given the fact that the patient was not able to access any anti-cancer treatment, he wasn't able to access radiotherapy directed to the wound to reduce it in size, I have a few questions for you and for our discussion. We've had some good discussion on the chat, so thank you so much for that. But how do you select an appropriate pain medication, and how do you develop an appropriate pain management plan for patients like this? You may see patients like this in your clinic as an outpatient. You may see patients like this in your wards. You may see patients like this doing a home visit. How do you come up with an appropriate plan to manage their symptoms? What do you do in your setting as a starting dose of morphine? And what do we know are some of the side effects? Some of you may not know a lot of side effects of morphine because this might be one of the first times you've joined into a session talking about morphine, but some of you have. Some of you have learned about different side effects of using opioids and morphine. So I'd love for you, if you can, answer one or all of these questions in the chat. This is now, we're moving into our time of discussion about this case. So I would love to also open it up to the group. And what I will do now is I will stop sharing my screen and I will put these questions in the chat so you can refer to the questions. But I would love to have some interaction and some chat with the group. So if you feel comfortable, again, this is a safe learning environment. We're all here to support one another. You're welcome to turn your video on and unmute yourself if you feel like you could contribute or you have any other questions about this case. It is a complicated case, I do know that. Okay, so I see a few things coming in. Yes, Ali, would you like to unmute and ask your question? Go ahead, Ali. You just have to unmute, Ali. Yeah. We can't hear you, Ali. Pole.
Erin, are you getting me?
Yeah, I'm getting you now. Yes, go ahead.
Yeah, in the management of that patient, we said in the first time for the pain management, we give morphine 10 milligram every 4 hours and PRN maximum for 1 hour.
Yeah.
So also it says regular Biscodine and 5 milligram.
Yeah.
So in that scenario, how do Biscodine help? And in that case, and I wanted a good clarification on that.
Yeah. So Biscodile we use for constipation, right? It's a form of a laxative. So we know the way that morphine works is morphine causes what the main, nearly 100% of the time, opioids cause constipation. So we need to make sure that as clinicians, anytime you prescribe any medication that has codeine, morphine, any type of medication that has an opioid in it, most likely that patient will experience constipation. And then what will happen, the patient won't want to take the medication because they're constipated. They'll get a bad interaction and then they'll stop taking their pain medication, and that's not what we want them to do. So at exactly the same time as we start them with a prescription of morphine, we always prescribe some sort of laxative. So some people use lactulose, some people use Biscodile. Do you have access to that in your clinic, in your setting?
Yeah, we have.
Okay, so I would suggest anytime you give a medication that has any type of codeine or any type of opioid, if you can access morphine, you always need to do some sort of laxative with it.
Thank you, Erin, for that clarification.
Yeah.
Thank you so much.
And you can, and I would definitely follow up. If a patient is opioid naive, so they've never taken opioids before, which most likely is the case. By the time you're seeing a patient, they may not have had access to a specialized pain, like a pain clinician. So maybe this is the first time they will be taking an opioid. We always suggest a laxative. And you do want to make sure anytime you do prescribe opioids, you have a follow-up appointment pretty soon after. Don't prescribe morphine and then discharge them for 2 weeks. You either want them to come back after a few days or you do a follow-up phone call. You ask them, are they having severe drowsiness and nausea or constipation? Talk to them about their side effects. Because most patients, if they have severe side effects, they'll stop using the drugs. And that's not really what we want, especially like when I shared this picture of this patient, you can clearly tell he will have severe pain. You saw how big his wound was. You saw that he had no access to anti-cancer treatment. no access to chemotherapy, no access, even surgery wouldn't help a patient like that. So we have to think of symptom management. Okay, I'm just going to go through the chat. It looks like a few other people are commenting, which is great. Okay, Lamek, I think you were calling from Nairobi, Kenya. You said, is there any other drugs which will help patients for pain relief, and what are the doses? So we will get into that when Dr. Esther, she has some charts of some recommendations of basic pain medication and what doses to start at. So that's really good. So that part is coming up, which is great. And then Hoden, you have a question. Why do we use morphine instead of other painkillers? We know that morphine is affordable, and we know that morphine is very good to treat cancer pain, advanced cancer pain. There are a lot of myths about morphine, and there's a lot of there's a lot of people are scared to prescribe morphine because of the myths that surround morphine. So I think that's often why we don't prescribe morphine with patients who have advanced cancer, because of the myths that clinicians are worried about. So some of those myths will be dispelled during our sessions like this, during our teaching sessions, when we have time to talk about it and when we have time to ask questions. Again, I mentioned earlier, this is a safe place to ask your questions. These kinds of communities, we're all here to learn and to support one another. Okay, you guys saw my question. So Stephen, perfect. Stephen answered one of the questions. He said, what can we do and how can we create a pain management plan? It's really important to teach a pain rating scale. So we need to make sure that we teach our patients. We might be having patients that are illiterate, so they may not understand a scale of 1 to 10. We may need to identify another way to teach a patient. Do they have a little bit of pain, a medium amount of pain, or a lot of pain? Using local language and numbers, local numbers. You don't have to use numbers 1 to 10. You can use numbers in your own language. And making sure we take a really good history is all essential to making sure that we have a good management plan. When you are a clinician, you need to document. So as you could see in this case, we were able to document the first visit, the patient had a 9 out of 10 pain. By consecutive visits, we said it went down to 7 out of 10, and then it was 6 out of 10. And then by the time we got the patient on a good regimen of their morphine, the patient's pain was well controlled. So that means the patient had a 3 out of 10 or lower. That is really what we're aiming for. Emmy is saying that it depends on how we assess pain. That's really true. Pain assessment is really, really important. Muriel, good. So we want to make sure when we prescribe morphine, any type of opioid, if the only prescription you give is an as needed morphine, you tell the patient to take it only when they have pain. This is not a good way to prescribe morphine. Morphine is a drug that goes through your system very quickly. After 4 hours, there's no effect of the drug in your body, which is why we suggest if you are giving immediate release morphine, you must give it by the clock every 4 hours. Once the patient has enough of the morphine in their system, we can then slowly transition them to a sustained release morphine. I'm not sure you can access sustained release morphine in many of your settings, so you may need to continue to prescribe Q4 hourly immediate release. Then using the latter, so that's what Dr. Esther will teach us shortly, and by mouth. It is the best way to give pain medication. We strongly suggest you do not give pain medication intramuscular. Intramuscular injections of pain medication are painful. So we want to avoid giving more pain, especially to patients like our one that we have in this case discussion. He's 35 years old and he has severe advanced cancer. You can see, remember from that picture, the amount of pain, not only the physical pain, but the psychological and social pain that he must be experiencing. We should not then add more procedural pain by giving an IM injection. Thank you, Muriel, for that. Leonard, so Leonard is suggesting that we manage the pain highly individualized. Perfect. So we need to do it based on each patient. Patient-centered care using the WHO ladder, which is great. He would start at 5 milligrams for hourly. That's okay. What you are comfortable with prescribing is really important. We don't want you to overprescribe if you're not comfortable. If you're the primary clinician, you need to start at what you're comfortable with prescribing. The thing, Leonard, I would suggest to that is you just make sure that you have a follow-up appointment very soon after he started at a low dose of morphine. So if you're starting with 5 milligrams for hourly, and you want to make sure you call the patient maybe after 2 days. Is it managing his pain? You don't want the patient to wait at home for another 2 weeks if you're doing an outpatient visit and the pain hasn't changed. He's still experiencing 8 out of 10, 7 out of 10 pain. That means you need to increase it. For symptom and side effects, very good. You want to make sure that you're thinking about their bowel movements using lactulose, bisacodal, and enema if needed. Perfect. Okay, Stephen is suggesting a starting dose based on weight. So that is true. We do need to think about starting doses if we have emaciated patients. So if you have a patient or you're dealing with pediatrics who are very low weight patients, you can use dosages based on kg. And then again, constipation. Perfect. You're right on line, Stephen, with that. We sometimes think of respiratory depression, but it is a very rare side effect of morphine, but it is something that you can teach your clinicians to think about in your inpatient settings. I think that's okay. Side effects, yes, we do need to think about constipation, nausea. If you have a patient who has recently started on morphine, you need to let them know that they may experience nausea and vomiting due to morphine. And you need to make sure that they can access anti-nausea medication quickly and easily. So if they're in a remote setting, you may want to prescribe them as needed anti-nausea medication to go home with. If you're planning to discharge them, you don't want them to get all the way to their home setting and then not have the right medication to access. All right, Vera has a question about tranexamic acid. So how many doses can we give to stop the bleeding? She uses calcium alginate. So that's something I haven't heard of, calcium alginate, but I'll definitely look into that. That might be an option. I think for the tranexamic acid, it works very quickly. So you would, I believe the tranexamic acid would be a one-time treatment. You would do it maybe as you're removing a dressing or if the patient is coming in with bleeding. Sometimes patients come into an outpatient setting and their wounds are bleeding and you're trying to get it to stop before you put the new dressing on. So that's when we would use the tranexamic acid. Again, if you are in a setting where the patient is not inpatient and you're not seeing the patient on a regular basis, you could send the patient home with the management plan and having use of tranexamic acid with that. All right, we have some other side effects, nausea and vomiting. Thank you, Hodan. Proper administration of morphine reduces the side effects. So we do need to make sure we're starting at proper dosages. So starting dosages of 5 to 10 milligrams every 4 hours are very good dosages to use. And making sure that all of our management plans include a laxative. If you don't remember anything from this session today and you remember that, I think that is really, really essential. Sometimes, yes, morphine does cause drowsiness, so we do need to let our patients know for the first few days after you start using morphine, you may be more tired or more fatigued. Okay, so we have a question here about the pain scale. So what we often use and what we try to teach our patients, if they have minimal literacy, is a scale of 0 to 10 or 1 to 10. 0 or 1 would be considered no pain at all. So this would be patients that are able to manage, they have good quality of life. Maybe they have advanced cancer, but they don't experience any pain. This could be neuropathic pain, it could be somatic pain, it could be pain from their tumor, it could be bone pain. It doesn't matter what pain it is, but we try to teach them this scale. We do this scale because we know that pain is subjective. What I experience in terms of my symptom of pain is very different than what someone else has experienced. So that's why we use a numeric scale. So often we try to teach the scale of 0 to 3 is mild pain. So some people can live with this kind of pain. Some people are able to manage their activities of daily living and they're able to cope well. Once you get to pain between 4 to 6, we call this moderate pain. So 4 to 6 pain, we probably would advise a patient to report that to their clinical nurse or their physician that they're working with. And any pain that is a 7 out of 10, that is subjective. So self-reported by the patient, not the parent, not the caregiver, it's the patient who reports their pain. If you have a 7 out of 10 pain, that's serious or severe pain, we would immediately want to treat this kind of pain. So we would want to make sure that we would assess what pain medications they previously had been taking. Maybe they got some drugs from a pharmacy. They hadn't advised us that they were taking tramadol, or maybe they were taking advanced Panadol, those kind of things. We need to make sure we know what they're taking, and we would need to adjust their pain regimen if they were reporting a 7 to 10 out of 10 pain. That's very serious pain that we would want to make sure we highlight. So Vera, it sounds like in Indonesia, you have access to a fentanyl patch. That's great. So sometimes in urban settings, we can access fentanyl patches to manage pain. That is a more longer term approach to pain management. And we often would start that on patients who already have been taking opioids already. So sometimes we would titrate people, or we would increase or adjust people to a fentanyl patch. And usually people can take fentanyl patches for up to 3 days. They last for 3 days. So that does really help. Pain assessment needs to be done, of course, Simon, before any prescriptions are made. Thank you. That's really great. Deborah, Dr. Deborah. Okay, so would metronomic chemotherapy such as oral cyclophosphamide tablets have palliative role in addition to pain medication and dressings? So Dr. Deborah, if you'd love to unmute, if you're still on the call with us, I would love to talk to you about this. I don't have as much experience with this kind of a tablet to manage symptoms, but it possibly could. I think anytime we introduce a chemotherapy agent, we just need to make sure we can access it. So depending on what setting you're in, being in a teaching and referral center, you may have access to that. Compared to someone in a remote setting or in a refugee camp. I don't know oftentimes if they would have access to that. But we do suggest, if you have the ability to incorporate palliative chemotherapy, we definitely see that as improving quality of life. So if that treatment could reduce his symptom burden, maybe it would help manage the size of the growth of the cancer. I would definitely suggest it. My background isn't in oncology with this. My background is more from the palliative side, but I think it definitely would be considered. I see we have a ton of messages. I'm just wondering if Dr. Esther, is your connection any better now? I'm wondering if some of these I could switch over and I can look through them and comment on the chat. But I know your connection wasn't so good.
Hi, Erin.
Hey.
All right, seems it's better.
Is it better? Okay. So why don't we switch over? There's a lot of comments. I have the ability to stay on the call a bit longer. So I will just make note of where I've stopped. I think maybe around Dr. Deborah's comment. So I'll kind of read through as you're presenting, Esther, and then we can definitely spend some more time going through all the comments. There's tons that have come through, which I think is really good. But why don't we switch over to the teaching time? And some of the questions might be answered actually through your session. Thank you so much, everyone, and keep the questions coming. I will make sure I answer, or we will try to answer all of them. Karibu, Dr. Esther.
Thanks, Erin. You could enable screen sharing.
Oh yeah, sorry.
Thanks.
Is it working
For
now?
the other device, sorry. No, the other one.
Oh,
The other
sorry. Yeah. Okay. All right, go ahead.
All right. Thank you. Thank you, Erin. I think we'll just build on what you have we've shared. And if I'm not visible or audible, sorry, please let me know.
Yeah, sounds really good so far.
Okay, thanks. In terms of pain management and use of opioids, we've had a lot of discussions so far. So maybe some of the feedback would be from the talk, but as we begin our session this afternoon, it's important to consider when we are choosing analgesics, you have to think of the severity. And there was the question of how do we rate pain? That will help you determine what choice of medication you would give. If we refer back to the patient that we've just talked about, where the pain is coming from, how long this pain has been there, the patient's age and other comorbidities. So this really says that pain management is should be individualized, and each patient or person will have a different course of action. So in terms of rating, we have the numeric pain rating scale that just helps us remember or document how much this pain, how much the patient's pain is. So ideally, you'd have a scale of between 1 and 10, where you'd simply ask your patient on a scale of 1 to 10, let me know how you would rate your pain. So what usually happens is they'll tell you, maybe if it's very little pain, you'll tell them that's a 1. And if it's too much pain, you'll rate it as a 10. So it's something that is, you can just write it in your charts or in your facility to help you count, but we don't have like a thermometer, a gadget that you'd use to rate pain. So it's highly subjective. So depending on what score they give you, as Erin highlighted, that will determine what type of medication you would give for this patient. So a score of 1 to 3 is mild pain, a score of 4 to 6 is moderate, and anything above 7 is rated as severe pain. And we'll look at what medications we can use depending on what the patient's score is. So if a patient has a pain score of 1 to 3, which we said is mild pain, we have what we call non-opioids, where someone talked about paracetamol in the group. Brufen, the non-steroidal anti-inflammatory agents, that's where they would fall in. If they give the pain score as 4 to 6, which we said is moderate pain, we give them the weak opioids, and weak opioids include medications like tramadol, codeine, which you can use for that. And then sometimes we also use low dose morphine, that's a dose below 5 milligrams for a patient, as a weak opioid. And then if the patient has severe pain, remember we said a score of 7 and above is rated as severe, we give what we call the strong opioids. And that's why morphine has been discussed earlier. Remember our patient had a score of 9, then the 7. So you see that falls in severe pain. Someone asked why we are using more of the morphine and not the other medications. So this is the reason. You have to rate it. And depending on the patient's rating, you would be able to know which specific medication to give. We also have things called adjuvants, or medications that are not typically pain medicines, but can be used for pain management. So things like antidepressants, we've used a lot of amitriptyline, which you might be aware of. Anticonvulsants, things like carbamazepine are also helpful. So if they have pain rated as or qualified as neuropathic pain, that is the tingling pain, the burning pain, if they describe it as such, we would add adjuvants to the medication. So for us to remember, you need to score the pain correctly. Then after scoring, you would know the severity, you're able to prescribe the right medication. Another important note is that this ladder moves from step 1, 2 to 3. But remember, when you're seeing your patient and you're assessing them, they come to you and they have a pain score of 7, for example, which is severe pain. You would give medication and review. If their pain goes down, you are at liberty to go down the ladder. If it worsens, you are at liberty to go up the ladder. So the ladder goes up or down, depending on your assessment of the patient. And it's good, one of you mentioned that you, for our case, you would have increased the dose, but monitored the patient so that you see if your medication is appropriate. So let's remember this slide even as we go into implementing pain management in our sectors. So I'll move forward to a few more things that are relevant in terms of pain management. So when you are assessing or taking care of these patients, remember you have to think of what the cause of the pain is. If it is something treatable, you need to treat it. If your patient, like this patient, has a wound, most likely the pain, some of the pain is coming from the fact that the wound might be big, it's covering an extensive area. Are we able to control the size of the wound? If, for example, they had a fracture, for that matter, are you able to repair the fracture? Are you able to put a cast or put a plate, do surgery so that you help reduce the cause? So you're also giving medication, but you're also trying to treat the treatable. And then look at what impact it has on the patient's life, and then determine the best control measures. And remember, when we are doing pain management, the goals of care have to be discussed with the patient. If they come with a pain score of 7, it's important to discuss with them and see, and especially if they had chronic pain, discuss and see what pain score would be comfortable for them, because sometimes for chronic pain, you might not get the pain to 0, but you should be able to improve their quality of life by using different aspects of pain management. We talk about total pain, and pain is not just physical. There are other 3 domains that we consider, including the social aspect. Patients might have lost their job because of their inability to attend to their functions or to go to work. So how is that affecting them? It might be causing more pain than the physical aspects that they have, psychological as well as spiritual. So you might find patients asking questions like, why me? Think of spiritual pain and think of looking at getting them a spiritual caregiver to try and manage that pain. Our counselors, our psychological team support is also very important. So even as we're implementing the physical pain management with the medications we've talked about, let's remember these 3 domains, and that is what we call total pain. So look at the person in totality, and especially in palliative care, because we know they're living with life-threatening conditions that are usually, most times, will be long-term. Our goals of care really depend on also the patient, but we try and cure where possible, relieve their suffering by managing their pain, and then improve their coping mechanisms, and also look at rehabilitation for this patient as well as their family. Because remember, the suffering is not specifically on the patient, but also could affect the caregivers who are with them. So the treatment plans need to be individualized, and we've talked about multimodal analgesia, and we look at more specific aspects of what goes into pain management. So some of the therapies we can use include, for the physical pain, we've talked about the WHO ladder. And this chart just gives us an overview of what options are available for us. I've talked about the antidepressants. We've talked about the anticonvulsants for neuropathic pain. Sometimes we have what we call interventional techniques, and this has also been referred to the step 4 of the WHO ladder, where now an anesthesiologist works with the team so that they offer things like nerve blocks. Maybe some of you have had that experience, or regional nerve blocks, or peripheral nerve blocks, depending on how the assessment of the pain is. So some pain might not be fully controlled with the oral medications that we've talked about, but if it stays on for a long time, please consider including an anesthesiologist to help with the pain relief. Then we also have the non-pharmacological approaches where we look at total pain. So you're looking at any aspects that might be an issue to the patient. Think of physical therapy too, cognitive therapy, nutritional counseling, behavioral modification, in addition to the other strategies that you will be implementing for your patients. So in terms of opioids specifically, we have these medications, a wide variety of them being in use since the early 1900s. So some of them are natural. So like morphine comes from it's a naturally occurring product from the poppy plant. We have that derivation from there. And then some have been semi-synthetic. So over time, as research is ongoing, we have more newer molecules coming that are better in terms of pain control. So for the opioids, we have either weak or strong opioids. And from the chart, I can see some of you have interacted with some of these medications. It will be good also to know what you have been using, what is available to you, and maybe what experiences you've had with the same. So the weak opioids we talked about included codeine, which we said we use for moderate pain, and then strong opioids like morphine, methadone, fentanyl, patch or injection, oxycodone are very good for severe pain. So in terms of morphine, general pharmacokinetics, it's a narcotic agonist, and it inhibits the descending pathways of pain. And because of that mechanism, it's able to produce analgesia and sometimes leads to sedation. So you'll see patients saying they're sleepy, and we usually tell them about that, but it wears off with time. Sometimes it may cause respiratory depression, suppresses cough, and that's how, if you look at some cough syrups, you'll find that they actually have something like codeine or an opioid. And part of the reason why at least for Kenya, the government was banning use of cough syrups was that you don't know what is actually in that syrup. So you have to be very careful, even as you give them to children. Another note is that for our, if we go back to this slide, what we term as weak opioids, the codeine, the tramadol are actually not recommended for children because of the side effect profile, and usually they're not able to break down the codeine to the active metabolites, so they end up with toxicity. So for children, we recommend when they have mild pain, you treat them with a non-opioids. Then when they have moderate to severe pain, we treat them with the strong opioids that we have listed. So in terms of morphine, we have access to the oral formulations, we have the solution, we have the tablets, and we have the injection. But when we are talking of chronic pain management, we recommend use of medications by the mouth. So as opposed to giving patients injections and inflicting more pain, are you able to give them an oral formulation that is even easier for them to take in? And you also have patches available. Fentanyl is available as a patch. which patients can also use. And in developed countries, and maybe our listeners or audience from other than the ones in Kenya or Uganda, and also tell us if they're also using the morphine patches already in their countries. So the oral morphine usually takes about 30 minutes for it to start acting. Then the IV has a faster duration of action that is about less than 5 minutes, and that's why it's usually used post-operatively. You'll find it being used in theaters a lot. This is important because when you're giving your patient medication and you're doing when you're doing patient education about the medicines you're giving, you tell them you start feeling effects within this duration of time, so that if that lapses and they're not feeling any relief, you have to rethink either the dosage or the medication you give the patient. And for oral morphine, we have it acting for about 4 to 6 hours. So our dosing usually for oral morphine is a 4-hourly dose or sometimes 6-hourly, based on different factors that we highlighted before. And we have peak plasma concentrations at about 60 minutes for the oral formulation. IV is shorter, that is in 20 minutes. And what happens is if a patient tells you they still have pain, maybe 2 hours after you gave them the morphine dose, oral morphine dose, you might be, based on your assessments and evaluation of the patient, it might be useful to give them what we call the breakthrough dose. So you give them another dose on top of the regular dosing and then see how to adjust the dose later. So for metabolism, it happens in the liver and eliminated in the kidneys. So if a patient has challenges with their kidneys or liver, it's important to adjust the doses or adjust the frequency of giving this pain medication, that is opioids. Some of the side effects we've highlighted include sedation, and I told you it wears off with time, about 72 hours, as well as the nausea and vomiting. Then constipation is something that they will most likely report of, and Erin talked about use of laxatives. So when you're prescribing an opioid, please ensure you give them a laxative like lactulose or whatever is available in your facility, so that we have patients not feeling the constipation and stopping the medication, pain medication in the first place. We'll also look at tolerance and dependence just shortly. So for the dosages, a highlight is that these are weak opioids. I'm talking about, if you're using the hydrocodone, that is the DF-118, usually give it at 30 milligrams every 8 hourly. And remember, for our dosing, we recommend that you mention the dosing by the hour, by the clock. So instead of saying take it 2 times a day, tell them the time that they're going to take it, so that we are sure that they're following the right schedule and the medication is effective to them. Otherwise, you will have patients reporting no pain relief. We have a maximum dose of 240 milligrams per 24 hours for DF-118, which is similar also for what we call codeine for pain management. So we also have another medication called tramadol, available as injection or tablets, and it also has a maximum dose of 300 milligrams per day. So keep those in mind even as we are giving these medications to our patients. Be careful not to exceed the maximum doses. For oral morphine, we have access to the oral morphine solution, and a simple way of remembering the dosage is 1 milligram per kilogram per day. So for example, the patient we discussed today, if their weight is 60 kilograms, for example, you could let me know if they're 60 kilos and you want to give them morphine at 1 milligram per kilogram per day, what do you think their dose would be? So usually we would do the weight, 60 milligram 60 kilogram per the times 1 milligram, and then divide that into 4 hourly doses. Some standard operating procedures recommend that you give them this dose that we've calculated for the day for this patient, our 60 kilogram patient, and divide it, give them like a third of that dose at night so that they don't have to wake up at night to take their 4 hourly doses. Then the rest divide in 4 hourly doses during the day. So in other terms, you're also saying that they are receiving sort of a double dose at night, but you need to review your patient and see if that is something working for them. But this is a formula. You could also share what you're also using in your facilities, because I know we come from different countries and different facilities. We also have the sustained release tablets, and these are available. Mostly, I've seen them mostly in the private facilities. Some government facilities do have them. And I talked to Ali earlier, and he mentioned that they also have these tablets with them. So these ones are easier to give because you give them in 12 hourly doses. So maybe one dose at 8 a.m., the next dose is at 8 p.m. Then we also have the IV and the IM formulations. That's an image of the morphine available to us, which is for Kenya currently being reconstituted at the Kenyatta National Hospital. And that is what most of our facilities are using if you get your supplies through the Kenya Medical Supplies Authority, that is KEHPCA. So for our patients that we talked about, I don't know if your questions are clear on why we opted to give them the specific medication. But when we talk about dosing and following up patients, we have good resources that you can use, you can refer to, so that you don't have to cram the figures. And but you need to know what is available to you and what formulas we actually use. We don't have a ceiling dose for morphine, but the patient's assessment or evaluation will guide you on what is suitable for them. Remember the other week opioids, I told you about maximum doses. For morphine, the ceiling dose is what works for the patient. So you need to just keep monitoring and reevaluating your patient. Don't give them medication for a month, especially if you're just starting and don't follow up. But you need either to call them or tell them to come back after 4 days or a week so that we assess the progress and see if there's anything that needs to be changed. So look at the age of the patient as you're prescribing. The elderly will actually require less doses or increase the duration of doses. And then if they have renal and hepatic impairment, we will have to reduce doses because I talked about the metabolism and the excretion. Then the doses are also changed in pregnancy and lactation. They're using other sedatives. You need also to adjust the doses so that you don't cause an additive effect. These two terms that I had mentioned earlier, just want us to remember and have that in our minds. There's something we call tolerance, and tolerance simply means that with time, this patient requires, or rather does not feel the effect of this drug with time. So in this case, if we talked about patients getting constipation when they use opioids, so tolerance does not happen, or tolerance does not occur to constipation. And that's why with time, as you give them the medication, you also cancel them and tell them, because we don't want you to get constipation, we are giving this medication. Another aspect is that for things like nausea and vomiting, we said it wears off in 48 to 72 hours. So you cancel the patient and tell them, we are giving you this medication, maybe an anti-nausea medication for 2 days, but later you will not need it. But the laxatives, you'll need it for a long time. There's a term called dependence, where now these patients will usually require higher doses to get the same level of analgesia or pain relief. And for dependence, because that is something that usually happens over time, you might find that you need now to change their doses. And some people have confused this for addiction and saying, this patient is asking for higher doses, it means they're addicted, I need to stop the morphine. You need to question that and see, is it really addiction? Because when we look at addiction, we find this as a compulsory disorder where the person becomes substance. So it's not for pain relief, but they're using it for recreational purposes for that matter. So just remember that a patient who is in pain will not be the one coming to you with a diagnosis of addiction or what we call opioid use disorder. So I'll just skim through this quickly to let us know that we have the DSM-5 classification where we name the opioid use disorder as one of the psychiatric conditions. And there are many things that you need to look out before you say this person has opioid use disorder. Previously, people would call it as addiction, but it's actually listed in the list of diagnosis for psychiatry. So in terms of the symptoms or the things you'll see in a patient, they'll be using opioids in larger amounts over a longer period of time than you intended them to, even when they're not in pain. They have this persistent desire to cut down opioids, but they're not able to. Then they have this craving. So you see the patient telling you, I crave, or I can't do major obligations if I don't take this medication. And then they are not able to keep up with their social and occupational activities. So you find these patients are usually using this over time without the medical benefits. So before you label your patient, please make sure we walk through the diagnostic criteria. So we'll stop there for now. And for further reading, I know there are many things that have been shared with us, even on the WhatsApp group, including the Google Drive documents that you can frequently refer to. And I'll open this up to questions. So back to you, Erin. Thank you.
Thank you so much, Dr. Esther. I think although we had technical difficulties, I really liked how the flow of the call went today. Because I feel like, of course, we had a lot of questions, but I feel like you definitely reinforced a lot of stuff we talked about during the case study. No. There was a question, particularly Dr. Esther, regarding renal impairment and using morphine. Do you have a comment about that?
Please come again, Erin.
What to do when patients have renal impairment or kidney disease and require pain management. I know I just shared the link, but I know that we do have to monitor the amount of morphine those kinds of patients get, but do you have any comments?
Yeah, so usually we would reduce the dose. If morphine is the only medication you have available to you, you'd use it, but at not at the dose we talked about, the 1 milligram per kilogram per day. If you have access to other safer, especially like renal safe, fentanyl is safer on the kidney than morphine is, you could change to that. But most times we would reduce the dose because we know we have, for us in Kenya, morphine is more available than the other options. Methadone is also an option, but we've been using it, or rather it's available to us for rehabilitation, not necessarily for pain relief. Yeah, so you still need to monitor your patients and yeah, and do an individualized plan even as you're giving the medication.
Mhm. Yeah, I think it's really important even to include their kidney specialist if they do have access, or even if you have a generalist physician that's providing the support for their kidney disease. I think it is really important to include those people also in the discussion. If they are experiencing pain, it's important from our perspective that you assess that and manage that, but maybe an open conversation with their other providers is really important too. I've shared a lot of stuff on the chat. I do hope you've had time to click on some of the links. If there are particular things that you would like to follow up on, or in your setting you feel like you don't have access to some of these drugs, this is just the beginning conversations. I think that in many of our settings that are remote, or in many of our settings that are humanitarian in nature, accessing opioids is not easy. And I think we stand together with you. Of course, Dr. Esther and I both live and work in Nairobi. So our situation is extremely different than many of you are facing, and we do stand together with you. We know that you face a lot of patients that are in a lot of pain, and there's not a lot you can do to get their pain below a 3 or a 2 out of 10. You just don't have access. But there is a growing number of us that are wanting to come together, to work together, to provide the best care possible to your patients that you face. And yeah, we're not going anywhere. I'm going to be around for the next several years in Kenya. Dr. Esther is Kenyan, and she's here, and she's committed to really pushing this agenda of allowing all people, regardless of where you are, regardless if you are a citizen or a refugee, to access good pain management. So I think I would like us to continue this conversation. If you've joined our call today, that's because you were seeing one of our advertisements, however you received it. We'd love for you to come to our next call. We are in the middle of our mentoring session. So we meet every 2 weeks at the same time. And I will be sending out another advertisement. Our next call is actually going to be on pediatric palliative care in humanitarian settings. So what do you do when you face a patient? It could be even a preterm baby who has a very poor prognosis. What do you do with a child who has a terminal illness? What do you do with a child who's been diagnosed with advanced cancer? And how do you support their families? These are topics we're going to talk about in our next call. Professor Julia Downing will be our keynote speaker. And she is the head of ICPCN, which is an International Children's Palliative Care Network. And it's a global network that really supports and tries to advance pediatric palliative care. So please do reach out. I will stop the recording now. I can stay on the call for a few more minutes. If you have something very particular you'd like to reach out to us, please ask. And if not, it's been really a pleasure. We've had people calling in from all over, it feels like today. So very warm welcome, and please join one of our groups, either Palchase or the WhatsApp group where we regularly interact. And if you would like me to contact you via email, please put your email in the chat before you leave the call today. Some of you, I have your email addresses, no problem. If you already get emails from me, then you don't have to add your email in. But if you are new to the call today and you'd like to be on our contact list, please share your details. It's been really great to meet all of you and see you all. If you have a minute to turn your video on and wave goodbye, that would be great. Thanks, everyone. And I hope we'll see you soon.
Thank you.
Bye.
Bye. Thank you. Thank you.